I was privileged to work with Mayank and Andrew, my co-conspirators on the study, and we're from Calgary, and we did this trial in several centers around the world. We were fortunate, I think, that, to be fair, Brett and Stacy, you took a risk on us and gave us a significant chunk of funding that we were required to do the study. We had additional funding from other sources, as you see listed here. ESCAPE was an academic trial, and as you see, registered there. So I think that's we can skip that. But I just would say that I think it's important to recognize that we are standing here today because a lot of other people worked very, very hard in the past on endovascular treatments. It started way back. Many years ago, and some of the people in the audience were key people. I did see Tony Furlan somewhere, and I know that he was a real mover and shaker in getting things started, and we should recognize that we're standing here because other people cleared the way for us. So I feel fortunate in that way, right? Thanks, Jeff. So we started ESCAPE with the idea that when we treat patients, much like Elad just said, we converge on the imaging suite and then we try to make a decision. Do we go to the cath lab, yes or no? And like many centers, we were also participating in trials, and we were doing this treatment in our center and trying to understand why was it that we were seeing some good outcomes and the overall trials were not. But our conception was that the decision to go to the cath lab was based on what you saw on imaging. And so that's our point of departure. We became convinced that these four things were the key things that needed to be addressed in the design of any future trial. We saw, certainly in North America, I can't so much speak for other parts in the world, but we felt that in North America, patients weren't all being sequentially randomized, and so we thought we needed to find a way to do that. We wanted a fast and simple paradigm because we did think that workflow was really important. The speed was important. And finally, I think we observed, as many of you did, that when the Mercy catheter was approved, it was a great boon to the evolution of stroke. And I think, I've said this before, that although it's likely that the FDA approval through the 510(k) mechanism did inhibit the generation of randomized trials, it unleashed a great explosion of innovation. And it's not clear that we wouldn't have had the innovation that developed and has developed into the retrievable stents that we see now without that approach. So I don't know where the balance lies. Those who do a lot of randomized trials think that it was terrible that that we weren't mandated to do it, like the Dutch Mr. Clean trial, where they mandated the only way you'd get a retrievable stent was in the trial. But maybe there's a balance, and I'm not sure where exactly that lies, but here we are today. We did ESCAPE in 22 centers. There were actually 23 that were activated, and there were 2 more just on the verge of being activated, so we had 25 when we actually stopped. 11 in Canada, 6 in the United States, 3 in South Korea, 1 in the UK, and it was actually Belfast, Northern Ireland, and 1 in Dublin. And our conception was to use a large window because we were going to use imaging to select the patients. We decided that the issue was that TPA is the standard of care, so our study was over and above the standard of care versus control. So if it was appropriate to get TPA, we recommended that all patients receive TPA. The imaging concept, I think, is there may be different ways to sort of butter your bread, so to speak. Our concept was to be very simple and focus on this idea of small core, proximal occlusion, and good collaterals. And then we also felt strongly about the idea that we wanted to work with people who were willing to work with us, and we went to see them and talked to them. We had meals with them, we drank beer with them, and we talked about that we wanted to have this quality improvement. We worked hard with them over the phone and in person to increase the quality of what was being done. Simple criteria, as you see here, and then the imaging side, which I'll show you in a minute. We did publish our methods. You're welcome to have a look at those. They're available. The imaging has 3 components in our trial. One was to just look at the plain scan, and this is something that I think people need to pay attention to, and I'd recommend to all of you please talk, certainly if you are imagers out there, talk to your physics people too. You can tune your CT scanner just like you can shim your magnet, right? You can get the right sequences, the appropriate energy, the appropriate, whether you use spiral or point and shoot type of technique, to get good contrastation between gray and white and understand what's going on. So we used aspects. We said if it was a large core 0 to 5, you are excluded. And so this is the example. This is a good scan where you have minimal ischemic change, if any. And this is a bad scan. You don't put them in, right? And it's very obvious, of course, but obviously it gets more subtle. We decided that it was important to homogenize the stroke population, and we didn't want to have people with stroke mimics or other things, or people without a target lesion. So I think this is the same in all trials, and this is the concept of using CTA. Our lesions were intracranial carotid and M1. Finally, we used a novel technique which was developed by Mayank in our place, evolving out of the need to be quick. And so instead of having essentially a CT perfusion study, we did a 3-phase CTA, single contrast. You just take the image 3 times, about 5 seconds apart. And what you essentially get is a time-resolved CTA. So the first image, the first, let's see, pointer, the first over here on your left, the first slice is your standard arterial weighted CTA. You wait a few 5 or 8 seconds, and you get a sort of mixed venous one, and you get a late one, and you essentially get a sense of the flow through the system. And there are lots of advantages to this. You get a flavor of the collaterals. And one thing I'll tell you, just because I've looked at both sets of images, is this gives you the identical information to a CBV map. Right? It doesn't tell you the perfusion, it gives you the CBV map. Helps you understand what the flow's like. So there are lots of advantages enlisted there. And Mayank and Bijoy have published their data. It's in Radiology online this month. I'd really encourage you to go look at that article. This is simple, easy, it's programmable on any spiral CT. You don't need any new equipment. We also had, I guess this is an example from the paper, just to show you that we have had these cases. I think, Elad, you made a mention of this, that sometimes it seems that even if you have a big perfusion deficit, you open it up, you get a small infarct. And this is an example where it seemed like there was a big perfusion, big core. And in fact, if you're really fast, you open it up. So you're not. This made us and makes me a little bit wary of CTP. It tells me, I think, that the perfusion imaging is highly specific, right? And but you may miss some patients who are potentially eligible for treatment. Get through that. The second part of our template was to be fast, right? And our concept again was to be physiological. Take a picture. Don't worry about when they came into the hospital. Take a picture, see what they're like when you get them, and then once you know what they're like, decide if you can treat them, right? So we wanted CT to groin under 60 and CT to recanalization under 90, and I think it's certainly possible to be super fast. The fastest time in the ESCAPE trial from CT head, first slice, plain CT, non-contrast head, to first reperfusion was 26 minutes, which means we got to the groin puncture in about 10 minutes from CT. So it's possible to be fast. There were obviously longer times. We did recommend, of course, the use of retrievable stents in the ESCAPE trial. We did not mandate use of the solitaire stent, although it turned out that in all those 22 sites, the one that was chosen most frequently was the solitaire, but other devices were used. And we also recommended use of balloon guide catheter to prevent distal emboli. We tried to design the trial for speed, and we did do some novel things. Canada, we are permitted under federal law. We used a similar regulation that is in the United States is called ETHIC, or exception from informed consent. So in some of our patients, a deferral of consent process was used. It was only half the sites that had that available to them. We used a dynamic internet-based randomization scheme. We talked to each of our sites, and we did ask the neurology and neuroradiology PIs to document their speed and then commit to us that they would enroll in consecutive patients. We used a lot of quality improvement. Each site, at least twice in each site, we had webinars and teleconferences about how do we increase speed and what does your imaging look like? Are you doing well? We were fast in enrollment because of that. I think it did benefit us, for example, to use deferral of consent. It did benefit us to talk about consecutive enrollment. And we had lots of good discussion about this across the email back and forth. But we did 1.5 subjects per site per month, beginning in February 2013 and ending in November of 2014. There's the deferral of consent. It was about 18% of patients. And our sense from the investigators was that this was actually very useful, particularly in the United States where this was not allowed. I don't know if any of the folks from Denver are here. Don Fry and his colleagues really made the point that the way their setup was, because they had a lot of patients being transferred in from peripheral hospitals, that it was really very difficult to enroll patients in studies because the patient would come perhaps by helicopter and there would be no family member available to provide the consent. So this is a key issue in research or emergency stroke research, and one that I think we need to address. And I'm hoping we'll have some more information as we go through our data in ESCAPE on this issue. As I said, we worked on quality improvement. We showed people their scans. We tried to train them on the way. We showed them their times. We told them they were in target or they weren't in target. We encouraged them to be faster. And I think it worked overall. It really helped us, right? We had low numbers of protocol deviations because of that, on the aspects, on the CTA, on the collaterals. And we were generally quite quick in terms of getting people into the study. Again, the bottom two are were the key metrics in our view the CT to groin and CT to reperfusion were our key metrics in our study. There they are, 51 and 84 minutes. We were able to get reperfusion in our study. I think Jeff talked about this, and Mayank made this point yesterday that in our core lab we had them actually do the traditional TICI score. So we didn't follow the guidelines, Jeff. Sorry, we should have done that. But so there's maybe some differences, but I think that the point is that the difference here is remarkable. The other thing I think that I would encourage you to do in your own shop is to think about to think about this issue is how well does TPA work? And I think we got a good answer here. So this CTA was done between 2 and 8 hours after randomization, and it was designed to be somewhat similar to the last runs of the angio once you got it open. So there was approximately similar times. And I think this is important because if you look at the 24-hour follow-up CTAs that have been done in other studies, you see very high rates of recanalization with IV-TPA. And here you see that it's quite a bit lower than angio. And the issue then is that IV-TPA might work, but it's too late, right? So it may work in 60 or 80% of people at 24 hours, but of course by then the brain's already dead. So this is why we did these CTAs in the control group. And I think you get a great number there to tell you what's in these big vessel occlusions. Just a little more than a third of the time the artery's getting open. There's the TICI-2B3. Again, Mike made this point that there may be some differences in the way things are done, but I think you see an evolution over the course of time, and I think it reflects the evolution of technology, allowed us and technique, right, to get these arteries open. So what happened in our study is we did have a pre-planned interim analysis with a standard boundary with an alpha spending function, and it was planned for several weeks after the WSC presentation from Dr. Dippel on Mr. Clean. Once that presentation happened, Mayank and I met on a Saturday morning. Andrew was on the phone. He was in Istanbul, and we were drinking coffee at a diner, eating breakfast with Andrew on the phone, and we made a collective decision that we should talk to the DSMB about this finding from the Mr. Clean study. And after we had done that, we made a decision to accelerate our DSMB review of the data. So it was accelerated by a few weeks, and our DSMB reviewed our data about 2 weeks later on November the 6th, and then made a decision to halt the trial. Here's some important data. Just in the left, it's not going to show up well. There were only 8 patients here in the intervention group who at the time of the first angio had their artery open. So 8 out of 151 there who actually had an intervention procedure. So the rate of spontaneous opening from IV-TPA at the time of first angio is low, 4 or 5%, which of course is a key reason why this works. Right? Here's our study. We had older patients up to age, we didn't have any upper age limit, and it was pretty well balanced. Severe strokes, as you can see there. Aspects same as SWIFT prime. We had, again, these distributions are very similar, about a quarter of patients with ICA-TNL. In contrast to SWIFT prime, we did have about 12.5% or so of patients, 1 in 8, had a tandem lesion, carotid and M1. And we actually found that this was actually a group that we ought to treat aggressively. There's the times, I've showed you those before. 3/4 of our patients got TPA. The ones that didn't, and here's, just to remember this, it's important. The ones that didn't get TPA were the ones that were not eligible for TPA. So when I tell you that it doesn't matter whether you got TPA or not, it's not really the same as taking all eligible patients for TPA and then saying that that you could go straight to angio. I don't think that's true. Like Steve said at the beginning, IV TPA is the standard. We should give it. If there's 8 patients out of 5% of patients you don't have to do a procedure on, that's still worth it. We showed a mortality benefit in our study. As you see there, it's about a 50% reduction. The hazard ratio is actually 0.4 on the adjusted basis, and that was, it's a remarkable thing. I think it's amazing to see that we're actually going to be saving lives from this procedure. We may be able to knock stroke off its number 4 killer in North America rate if we get going on this procedure. Pretty safe. We didn't see any major difference in hemorrhage. Large strokes were reduced as you would expect. We did have some access site hematomas. 2 were in the groin, one was in the neck. We had a particularly aggressive team in one particular site who's willing to do common carotid puncture, and they got into trouble with one case who remarkably opened up the artery, had to have all kinds of stuff done on the neck and closure and a cricothyroidotomy, and then went home. So amazing story, right? We had 1 perforation. And then we did have a number of, now these safety outcomes, I should tell you, are the serious adverse events. So these were the ones that resulted in trouble. There were more femoral bruises and pseudoaneurysms, which were easily treated. So they were just considered normal adverse events. Angiographic outcomes I've shown you, 86% retrievable stent use, 80% of those, or 78% of those were solitaire. Outcomes, there they are. I think we've shown them before. We had a shift, if adjusted shift is 3.1, and a approximately 24% independence rate. So the traditional NNT of 4, if you do it across the whole odds ratio scheme, it's 3. And we did show, in contrast to the Mr. Clean study, we showed that there was an improvement in quality of life scores at 90 days. There's the overall results. Really an amazing shift, as has been said. So really exciting stuff. IV TPA, same thing. We got a big shift. Now we had a smaller number of non-IV TPA groups, same shift in outcomes. This difference in death rate is not statistically significant, but it's just the small numbers. I think we'll have to sort out what that means. Here's the mortality curve. You see that obviously it's the deaths that are occurring early. Once you get out past 30 days, it's the same. So we saw this reduction, and it really, much as Jeff showed, it's the same all across the spectrum, all in the difference. So age, older, younger, and remember we had no upper age limit, so we had about a quarter of our patients were over 80. Good and bad scans. Remember though, or good and moderate scans. We excluded people with bad scans, and you saw from our previous data that we were good at that. We excluded them well. IV TPA or not, but remember again, the not were the people who were not eligible for IV TPA. So it's a different issue. It's saying that you should necessarily, it's not about going straight to cath lab, I think. We'll see. We'll talk about that, I'm sure. And then all the way down. Here they are. And I'll just tell you that I'm running a little bit out of time here, but we did, just so you know, that obviously you'll all know that this is published, it's online, and we produced an extensive supplementary appendix with all of these figures in there. So I would encourage you to go and look online. We've got the stratified by age here. You see the older folks, they don't do as well overall. There's a higher mortality if you don't treat them, but the effect size is there. Men and women about the same. NIH score, moderate and bad, effect size is there all the way. Certainly the big ones, you're clearly saving lives. Onset to randomization time, 3 hours or more than 3 hours, you got a good benefit. Subgroups, right, imaging, whether you had good or moderate scan, et cetera, all good. There's the aspects. We had very few below. We had a few, protocol violators, so we can't really comment about the bad ones. ICA occlusion, this was important, we think. We think this is probably an important signal that we should be going after these ones who have tandem occlusions. Consider, have to sort out how to stent them, et cetera, or not. Where was the occlusion? Was it in the ICA or the MCA? We still had benefit either way. And the effect size is overall large, as we say there. So we concluded it's a safe, highly effective procedure. It reduces disability. I'd like to emphasize what Elad said. One of the things we didn't do, which was we did not collect screening logs in the ESCAPE trial, because generally speaking, screening logs give you very poor quality data, and it's hard to make any heads or tail of them. So we didn't think that was required. But it means, though, that I can't tell you exactly how many people were screened by imaging and then not included in the trial. Nevertheless, a rough estimate from our center in Calgary is that about 50% of people who we screen, we image them with CT and multi-phase CTA. We did not enroll in the study because they had occlusion in the wrong place, they had an aspects of 3 or 4, or they had completely terrible collaterals and they weren't eligible. So if you choose them with imaging, and if you are really fast and get your act together and get your group working together, and if you use safe, effective technology, I think we're going to be able to reproduce this study, reproduce these results, and get even better. So our key messages are: use the imaging, image the physiology. It's not so much about time. Then once you've imaged the physiology, you decide they're in good shape, you better get on with it in a super fast hurry. So put your running shoes on and work your team. It's a sprint. Get the artery open. You got to work as a team. We think it kind of looks like this, right? That the CT perfusion studies are really highly specific cases. They're the ones that you've identified with high specificity. They're going to be the ones to benefit. There may be a few others around, and we'll have to work. I think we're going to have to argue about what's the best imaging technology to pick these people out. But everybody showed benefit. Isn't that the bottom line? We've showed that this works, and now we have to figure out how to implement it. Again, as I said in our presentations yesterday, I'd really like to thank all the patients, their families, collaborators, 22 sites around the world. It's fantastic. Our Calgary team was terrific. Our funders, amazing collaboration to get this all done. Thanks very much.